the topic is treatment sequencing in MPN. So maybe a first question about when to start a JAK inhibitor therapy for patients with myelofibrosis. For example, if we consider a patient of 55 years old with a splenomegaly of 10 centimeters below the costal margin, slightly symptomatic with slight abdominal discomfort, some night sweats, blood counts near normal, let's say 11 grams of hemoglobin, 200 or 150,000 platelets, normal leukocytes. Would you start JAK inhibitor therapy in this patient? And what are the key parameters that make you consider to start such a treatment in myelofibrosis?
I think it's really important to take a look at the patient in front of you, to think about the symptom burden and to really properly assess that, and to properly think about the spleen size and any dynamics of change for that patient. And then think about what your future plan would be. So, and then also for many of us, it's going to depend on, there are plenty of times we would like to use a JAK inhibitor, especially in the UK, and we're not permitted. So we can't use, for example, for an intermediate 1 risk patient, but we might like to. But I think those are the things that I would be thoughtful of. And what I'm really mindful of is, increasingly the data suggesting that the earlier we treat these patients, the better in terms of being able to keep dose intensity, and also the data that we looked at recently and presented across the Comfort 1 and 2 studies, suggesting that those patients who were treated within 12 months of diagnosis did better than those who were treated beyond 12 months of diagnosis. I don't know what others think about that.
If I can just say a few words, I fully agree with you. And in Germany, we have the luck to be able to treat patients with intermediate 1. And as you said, I think we have so much data now, real world data, to showing that we do have a survival benefit for patients treated with adequate doses of ruxolitinib. And this is one very important consideration we do think about when considering treating earlier, especially if the patient is young.
Okay, maybe now about the switch of therapy. Let's say that you have treated this patient with a JAK inhibitor, ruxolitinib, for example, with nice response, reduction of the spleen, feeling better, etc. And after a couple of years, the symptoms come back, especially night sweats come back. You increase the dose of ruxolitinib to 20 milligram BID, but then the platelet count drops. What could be your strategy in such a situation?
I would try to reduce the dose first and to see whether the reason why I started treatment could be because the patient has symptoms. Maybe by reducing the dose, you can control symptoms. If the spleen is stable, I will continue with the reduced dose of the same drug.
In the US, if one develops a problem of initial response and then loss of response to ruxolitinib and worsening symptom burden, and then lack of benefit at higher doses of ruxolitinib, I think you have 2 options now that's available to us. One would be fedratinib, in which my personal experience and clinical trial data would support one to rescue both spleen and symptom burden in patients who had lost response with ruxolitinib. If the platelet count is really compromised, and when I say really compromised, I mean, I would say less than 100,000, for example. In the US, at least now, as of February 28th, we have a 3rd option, which would be as a commercial. So it expands the options. I think in both cases, one needs to be aware of the different toxicity profile associated with the drug. So GI toxicity with both agents, fedratinib, is more prominent than with ruxolitinib. So preparation for that is needed to be aware of that. But I think sequencing to the next line of JAK inhibitor therapy should always be considered, particularly if you don't have access to clinical trial options. So the other answer to this question would be, patients should always be considered for a clinical trial option available, an add-on strategy to ruxolitinib.
What about a bone marrow transplant? Should we start to think about since the beginning in these patients? I mean, to prepare the patients to do HLA, to study the family, to look at this. I think this is the first choice for a patient like this.
So I have to say we tend to work transplant eligible patients up at the time when we're starting ruxolitinib, but
exactly.
If the patient has lost their response and the platelet count's dropping, then it's important to also think about disease progression, and also then you might need to try to get a better response for the patient again, maybe by switching, as you suggested, John, or maybe adding another agent, because I think the data is quite clear that if you wait until the patient's clearly losing their response, then they probably don't do so well, and it's not quite ideal. But your point about transplant consideration really early and being ready is an important one. I think sometimes if you're in an area where there's no option for fedratinib or no option for pacritinib, for example, then the other option you have is to try to layer something else on the top in clinical practice outside of a clinical trial, like thalidomide or danazol, and then trying to maintain a better dose of ruxolitinib. And some people would discuss maybe withdrawing and rechallenging, but I'm not a big fan of withdrawing and rechallenging.
And I think to Tiziano's point too, is that the two approaches are not mutually exclusive. So one can look to cycle the JAK inhibitor while preparing for the transplant, because the transplant, I agree, it should always be, transplant remains the only curative option. So it should be entertained early on, and donors should be identified early on. And in my mind, at any sign of loss of response, that should be the exit to transplant. Sometimes in process of doing that, one needs to better control the spleen and the symptom burden while getting to transplant.
Maybe a few words from you as experts. So what are the new other alternative classes of drugs that you think will be the most promising for the treatment of MF in the near future? I know that we don't have access to these drugs outside clinical trials yet, but what are your favorite classes of drugs that you think may change the outcome of our patients in the future?
If I may, I personally believe, and I think it was very promising to have the add-on strategy. I think this is very, very promising. We have now many clinical trials, BET inhibitor plus a JAK inhibitor, a P3IK delta inhibitor also seems to work very well. Navitoclax, I think, I personally think that this add-on strategy might be a good option in the next coming few years.